Well, first of all, I must say that I'm happy that I participate in this project. We started more than 3 years ago, and I can very well recall the first meeting when there was a kind of a little bit maybe skepticism how it would work, how shall we design the study. John McMurray is the chair, so I can very well remember the discussion whether we should, whom shall we recruit, shall we go for HFrEF, shall we go for HFrEF and HFpEF. We decided, shall we go for diabetics only or shall we go broadly? At the very initial stage, we decided we go for HFrEF, and we decided we go for everybody. So we estimated that around 30 to 40% of patients would have diabetes anyway, but 60% would not. And I think it was a perfect decision. After these 3 years, we accumulated more and more data. Well, promising data, but still we needed to have a final piece of evidence, which we now have. So to make long story short, reduction in combined endpoint of cardiovascular mortality and heart failure hospitalization, but also magnificent effect on the cardiovascular death and heart failure hospital admissions, but also heart failure visits, which we call burden for heart failure, I would say exacerbation. Both in diabetics and in non-diabetics, which is particularly important from my perspective, because we always believe that this drug wouldn't be just for diabetes. So you can challenge me asking how it works. The trial is not meant to answer this question. We can speculate, but I am sure you don't need to speculate. But my reaction is great data, if only now can implement this into clinical practice, for which I believe we need more time. We need to communicate this properly to people. We need to convince physicians this is going to be really a major breakthrough, because please remember that these patients were optimally treated. These patients were receiving AC inhibitors or angiotensin receptor blockers, or if not, 10% received sacubitril/valsartan. Mineralocorticoid receptor antagonist, 75%. Virtually everyone on beta blockers. So the concept of neuroendocrine blockade is there. So this is on the top. So it's most likely completely different mechanism. So we have this data. These patients were also, many of them had devices. So this is a really very, very strong piece of evidence that it should be positioned, that the drug should be positioned in the guidelines. We have now 2021 guidelines scheduled, so 2 more years. I cannot predict how physicians across the world will see this if this is not the guideline statement. How they say, well, they may say, okay, this is not, we better wait, etc. And then, so maybe Heart Failure Association, which mission is somehow to interpret that results and place this into the guidance, should issue a statement, because there is no doubt that it works. We are all looking for the next trials. As you know very well, EMPA, gliflozin trial in both heart failure with preserved and reduced ejection fraction will be released soon next year. We are all awaiting the results for DAPA, gliflozin in HFpEF patients to close the whole perspective. So I'm really looking forward to see more and more. I personally think that this would be extremely efficacious drug also in patients who are admitted with decompensated heart failure, but it is a little bit off-label use, so I don't want to speak about it. So I think that would be my reaction. I really believe that we have a completely new drug which improves patients' outcome. That's what we really want.